Thank you for joining us for the Pacific Spine and Pain Society's webinar series. Tonight, we're talking about inequalities in medicine and the data behind it. We will be holding off for just one more minute to allow people to log on, and then our moderators will begin the program. Thank you for joining us for the PSPS training webinar series. Tonight, we were talking about inequalities in medicine and the data behind it, and our moderators will now begin the program.
Hello, thank you so much for joining us tonight. As you know, my name is Eric Lee, and I'm president of the Pacific Spine and Pain Society. And I'm very honored tonight to be co-hosting a very important webinar series with my colleague, Dr. Lawrence Perret, based out of UCSF. And tonight, it's important to kind of understand the magnitude of some of the challenges we face in medicine. The value of this webinar is to truly get a firsthand view of what the challenges are in our workplace, for our patients, and for delivering healthcare as a whole to all the different communities and patients we treat. So to spend some time to talk about the historical context, to understand the data behind the inequalities in medicine, identify some of the challenges in patient access to care, recognize a lot of the different types of biases in both workplace and the effects those biases have on treating patients, understand how outreach can help improve patient outcomes, and also develop a knowledge base to help us create strategies to overcome all these biases. We have no hope in treating this challenge unless you truly understand the depth of it. And with that, I'd like to introduce my colleague and co-host tonight. I'm honored to work with and a mentor of mine, Dr. Lawrence Perret. Lawrence?
Well, Dr. Lee, thank you very much for inviting me to join you on this very important webinar. We have a lot of great panelists here. We have, as you can see on the screen there, Dr. Jamel Lee, Dr. Ramo Naidu, Dr. Deborah Durica, Dr. Casa Mir-Delfan, Dr. Brittany Grovey, Dr. Stephanie Vanderpool, Dr. Jonathan Gore, and Dr. Jason Pope. I think we should just go right ahead and start focusing on our agenda. We're going to start off with a presentation by Dr. Jamel Lee on the inequalities of medicine and some of the historical background. So Dr. Lee, can you come on to the collection? There you are.
Yes, good evening. Thank you everybody for joining. I'm glad you guys are able to have us today. I'm Dr. Jamel Lee. I'm a practicing pain specialist in San Diego at Relive Youth Center for Advanced Pain Management. Great, I would like to go ahead and get started with the presentation. All right, next slide, please. Fantastic. So there's a couple of objectives for the conversation today. Our goals are to review landmark studies addressing health disparities, highlight the contributions of structural inequities to health disparities, identify goals and strategies to reduce them, and increase our awareness for personal growth, advocacy, and policy change. To get started, I would like to read a quote from Dr. W.E.B. Du Bois. "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." This is a quote from Dr. Du Bois' book, The Philadelphia Negro, published in 1899. Dr. Du Bois argued at the time that racial differences in health were largely the result of social inequities, as opposed to biological racial inferiority, which was the leading theory of the time. Next slide, please. This inequity is reflected well in the story of Anarcha Westcott. She was a 17-year-old female born into slavery with a history of severe rickets and a pelvic deformity that complicated childbirth, resulting in pelvic trauma. She would endure 30 operations to repair vesicovaginal and rectovaginal fistulas without anesthesia and without any record of her consent. OBGYN J. Marion Sims operated on Anarcha and also purchased other enslaved women for experimentation. He is quoted as saying, "Blacks do not feel pain the same as whites." This treatment of Anarcha represents how the exclusion of basic human rights can create multiple health inequities. Next slide, please. Religion and other pseudo-medical rationale were often used to validate the unequal treatment of African Americans and justify their exclusion from society, while at the same time promoting white supremacy. An example from the literature is an article by Samuel Cartwright, a physician in the 1850s. He was arguing that the unequal treatment of African Americans was ultimately best for their own biological prosperity and spiritual well-being. He argues this by describing two novel diseases. One is drapetomania, or the disease that causes Negroes to run away, that apparently develops if the white man attempts to oppose the deity's will by trying to make the Negro anything else than the submissive knee-bender, which the Almighty declared he should be. He also describes another novel disease, the dysesthesia ethiopica, and he describes it as a type of laziness in free African Americans and slaves that lived as if they were free, who ultimately lacked the necessary spiritual guidance and purpose granted to them by their white superiors. Next slide, please. Now, although these theories are no longer formally taught in medical schools, the DNA of these misconceptions unfortunately remain in our society and appear to influence our perceptions. A recent study looking at survey data found that some lay people and even some medical trainees share false beliefs about the biological differences of African Americans. And the presence of these false beliefs is related to racial bias and pain perception. On this slide, you can see a few of the questions, a sample of the questions. Some of the questions were factual, and some of the questions were designed to represent false beliefs. Of the lay people, 20% endorsed believing African Americans had less sensitive nerve endings than Caucasian patients. Even more believed that African American blood coagulates more and their skin is thicker. Of the medical trainees, the numbers were drastically lower. However, the false beliefs were present. Next slide, please. After the survey, the participants were asked to assess the pain scale of African American and Caucasian patients. In Figure 1, it shows that in lay people, those with higher false beliefs were more likely to underestimate the pain scores of African Americans compared to Caucasians, while those with lower levels of false beliefs did not demonstrate significant influences in pain rating. Figure A to the right at the top is from the medical trainees, and it's somewhat similar to the lay people, showing that with higher false beliefs, they were associated with lower pain ratings for African Americans. The medical trainees were also asked to choose an appropriate treatment plan for their patients. And this is represented by the data in Figure B, which shows that with the Figure B is on the right to the bottom, and it shows that for those with higher levels of false beliefs, they were less likely to recommend the appropriate treatment plan for African American patients. The conclusion was ultimately that the data suggests that racial bias may actually affect the clinical decision making. Next slide, please. This was long suspected, dating back to the 1800s by scholars like Dr. W.E.B. Du Bois. However, the first study specifically looking at racial health disparities was the Heckler Report in 1985. And it noted that African Americans were about 3 decades behind Caucasians in life expectancy and infant mortality. The Heckler Report led to more research and ultimately led to the landmark study, Unequal Treatment, by the Institute of Medicine. And this study, they concluded that minorities tend to receive lower quality of care even after controlling for access, and that these disparities are rooted in the historical and contemporary inequities that we share as a society and may manifest at the system, provider, and patient level. Next slide, please. Looking specifically at the clinical encounter, the authors presented evidence of unequal treatment. From a study by Van Renberg looking at actual clinical visits, they demonstrated that even after controlling for income, personality types, and education, physicians were more likely to have negative views of their African American patients. 2 additional studies used actors with identical clinical presentations. Weiss looked at acute pain from renal stones and low back pain and showed that male doctors gave more medication to Caucasian patients and males respectively, compared to female doctors who gave more medication to African Americans and female patients. Schulman conducted another actor study using actors who presented identically for acute chest pain, and they demonstrated that African American women were significantly less likely to be referred for cardiac catheterization. Next slide, please. This slide is essentially designed to represent the actors that were in the study for the Schulman study for cardiac cath. These patients or these actors had the same history, and they were more likely to be recommended for cardiac cath. Next slide, please. While the next slide shows African American actors who again had the identical clinical presentation, but were less likely to be recommended for cardiac catheterization. More recent studies since the unequal treatment landmark study came out in the early 2000s have substantiated these findings, particularly in the field of pain management and cardiology. Next slide, please. The previous cases represent healthcare disparities, which are considered a little different from health disparities. Healthcare disparities are generally not access related and may reflect bias, prejudice, discrimination, and uncertainty during a clinical encounter. Health disparities are generally the result of one or more social determinants of health, such as income, education, or access to healthcare. And inequity signifies a certain level of injustice. Next slide, please. In a fascinating TED Talk from a few years ago, Dr. Tony Iton asked a question: does your zip code matter more than your genetic code with regard to health? And this question was influenced by his differences and his experiences growing up in Canada and then training in inner city Baltimore. Next slide, please. Dr. Iton, who I believe was the Alameda County health director at the time, was reviewing death certificates in Alameda County and ultimately demonstrated that in some zip codes, people could have more than a 20-year difference in their life expectancy compared to their neighbors. This is a figure of Alameda County. The green represents zip codes where their life expectancy is more than 80 years, and the red represents life expectancy is lower than 74.3. However, there were some areas where the life expectancy went down into the 60s and even 50s when the study was replicated throughout the nation. Next slide, please. In one of his more recent presentations, Dr. Iton addresses the concept of policy violence that he defines as policies specifically used to maintain exclusion as a root cause for these health disparities. An example of such policy violence would be forced racial segregation from policies such as the Native American genocide, Jim Crow, redlining in the housing district, all of which contributed to tragic conditions of low income and low education. And both low income and low education are associated with lower life expectancy. In addition, these communities may have other health disparities due to poor potential exposure to environmental hazards, limited access to quality health care, and overcriminalization. Next slide, please. As mentioned briefly, Dr. Iton replicated his zip code study from Alameda County to many major cities throughout the country and ultimately yielded identical results. Recently, he also addresses that we have a potential to improve these health disparities with more efficient healthcare spending and increased support and with increased support of social and preventive services. He highlights the examples in other developed countries, particularly for impoverished communities who have had effective, cost-effective treatment of care for these patients and have seen improvements beyond what we've been able to see in the United States. Next slide, please. This next slide is somewhat short, but it highlights the significant disparity in per capita healthcare spending for Native Americans, showing they receive approximately 1/3 as much funding compared to Medicare and about 1/2 as much funding compared to Medicaid, which is essentially our safety net program. Next slide, please. So we talked about some of the social influences to health disparities. Switching it up a bit, let's discuss some issues at the systems level. A recent study in 2019 demonstrated how machine learning or algorithm bias may contribute to disparities at the systems level. It was an independent review of a national algorithm that's used by a major health plan. I believe it was Optum, but I found some conflicting data for that. Nonetheless, this algorithm calculated a health risk score to identify sick patients and enroll them into a chronic care management type of plan for more efficient use of care. They looked at about 50,000 patients with a 70-30 split between commercial insurance versus Medicare. Next slide, please. The algorithm used multiple variables or labels, including cost assessment, to calculate the risk score. This risk score was then used to identify patients who would benefit from the program. The graph to the left shows that for an identical patient risk score of 97%, 97% is represented by the dotted line, and it also represents the cutoff for auto enrollment. So if they reach 97%, they're automatically enrolled to the program. Well, at the 97% auto enrollment mark, African American patients actually had 26% more chronic illness. And since they carried more chronic illness but had an identical risk score, this effectively restricted their access to the program. Of the total program participants participants, African Americans represented about 70% of the population. However, in simulations correcting for this algorithm bias, enrollment was estimated to increase to 46%, almost increased by 30%, which is shown in the graph to the right. Next slide, please. The authors ultimately discovered that this disparity was due to a discrepancy in costs from treating African Americans compared to Caucasian patients. We ultimately assumed that sicker patients would need more, which should cost more. However, this was not the case, as African American patients were actually sicker, they had higher risk, and technically needed more, but actually cost less compared to Caucasian patients. The authors concluded that this discrepancy between need and cost suggests an underutilization of healthcare. This graph is the graph above is of the mean total expenditures or cost. The graph to the left is cost according to the algorithm risk score, and the one on the right is cost according to the chronic conditions. This algorithm relied on the algorithm risk score, but in the study they separated the chronic conditions to see if the data was concordant. Ultimately, what they demonstrated was that Caucasians had higher costs across the board, despite African American patients being sicker. And since Caucasian patients had higher costs, they were calculated to have higher needs, which increased their risk score relative to African American patients. Next slide, please. Ultimately, using costs to assume needs does not account for underutilization of healthcare, and ultimately reinforced racial bias against African Americans and restricted their access to the program. This study demonstrates how label bias, choosing the appropriate variable, may reinforce structural inequities. Also, which is very interesting, when the label was replaced, simulations demonstrated increased enrollment. This suggests that these disparities can be reduced and potentially even eliminated with effective label choice. And I found this article to be encouraging because it highlights a simple and cost-effective solution to help reduce health disparities. Next slide. I believe this is the last study we'll talk about, but another strategy to ultimately address disparities in healthcare, another strategy to address health disparities is to increase workforce diversity and representation. This was a recommendation by the Institute of Medicine's groundbreaking report, Unequal Treatment. A recent study in Oakland showed that African American patients were more likely to participate in preventative medicine screenings and invasive tests if they saw an African American doctor. The study had two stages. The first stage, patients were randomized to a physician, and after seeing the physician's face on the tablet, they would then select from a choice of screening tests. In the second stage, they would meet with their physician in person. After meeting the physician in person, patients could then revise their selections. The image on the right shows that after meeting with an African American physician in person, African American patients were 18% more likely to take up preventive tests and invasive tests. Next slide, please. The next slide demonstrates identical results for the invasive test arm. The invasive test was considered the flu shot. That was considered invasive. The figure to the right is from survey data of an identical patient population, about another 1,300 patients, but not this specific patient population, but in the same county. And it shows that the majority of patients, whether they're African American or Caucasian, feel more comfortable and feel they can better relate with the racially concordant doctor. Next slide, please. The ultimate conclusion from this study was that a diverse workforce may help to improve utilization, which we saw was from the algorithm bias. There's an underutilization between African Americans, and potentially this can be addressed by diversity in the workforce. Also, they estimated that with adding diversity to their workforce, we could potentially reduce costs and improve healthcare outcomes. I also find this article encouraging because it's a clinical trial. I'm used to using clinical trials and managing patients, and not necessarily how we run our practice, but a clinical trial for workforce diversity with positive results, I think is pretty intriguing. All right, and next slide, please. And I believe that's most of the data that we wanted to cover. I do want to send a special thanks to the NANS Diversity and Outreach Committee and Leadership Committee for collaborating with us and sharing some wonderful data. Thank you.
Terrific. Well, thank you very much, Dr. Lee. That was a fantastic review. We do have a number of other speakers to move forward with, but I would like to ask you one question.
Yes.
Racial injustice and inequalities and bias in healthcare are longstanding in the U.S. So why is it getting more attention now versus, let's say, 20 or 30 years ago?
Yes, I think that question is somewhat multifactorial. I think unfortunately 20 or 30 years ago, the problem certainly existed. I think now we have a growing body of evidence from the medical standpoint. I also think now for the last 5 years or so, there's been a level of social unrest. And I think this social unrest is leading to some generational change from essentially the top all the way down from multiple individuals. And I think building on the body of evidence that we've been collecting over the last couple of decades and the social unrest kind of creates the equation where now we can hopefully have some positive change.
Terrific. Well, thank you very much, and stay on. We'll have questions at the end as well.
Thank you.
That
Welcome,
was excellent, Dr. Lee. And I think one of the other interesting factors about the data that you mentioned recently, why has that come about, is the Affordable Care Act. That led to a lot of tracing of finances and outcomes going forward, which leads us nicely into our next session hosted by Dr. Naidu and Dr. Durica to talk about the challenges to access of care. So with that, I'll let you guys take it away.
Thanks, Eric. Good evening, everyone. My name is Ramo Naidu. I think many of you already know me. I'm a pain physician in Marin County, just north of San Francisco. I am honored today to talk with Dr. Durichka from Anchorage, Alaska. She has done quite a bit of work with AHRQ regarding elements of access to healthcare. I'm going to let her introduce herself, and then we'll get into our content.
Thank you, Ramo. So as Ramo said, I'm working in Anchorage, Alaska. I am not native to Alaska, but I did relocate up here. I work for Dr. Luke Liu, and Neuroversion is his pain clinic. Basically, I'm his consultant scientist. I do a lot of communication work. I also maintain a relationship with the Alaska State Department of Health and Social Services, specifically in the Office of Substance Misuse and Abuse Prevention. And the statewide action plan for opiate misuse is really a nice piece of work. Today I'll be talking about some data from the AHRQ, as Ramon mentioned, that is the Agency for Healthcare Research and Quality, which is actually from the Federal Department of Health and Human Services. So when we're talking about access to healthcare, AHRQ identifies 4 main areas that are important, namely coverage, services, timeliness, and workforce. So coverage is basically affordability and availability. We know uninsured people are less likely to receive medical care and more likely to have a poor health status. Services means the availability for a source of care. Having a usual source is associated with more screening and preventative services. And as I'm not sure what you see, but we definitely see a lot of our patients in the pain clinic without primary care providers. Timeliness, ability to get health care when you need it, because delays worsen outcomes. And finally, workforce. As Gabrielle mentioned, concordance between provider and patient leads to better outcomes.
Great.
Next slide. Great.
Perfect. So we're going to do a back and forth. I'm going to ask Deborah a few questions here. Firstly, I think many of us don't really understand what the diversity of our physician workforce is in the United States. What does the American physician workforce look like as far as race/ethnicity?
Yeah, it's not very colorful. If we look at the numbers per 100,000, you can see that whites are very much overrepresented compared to Black and Hispanic. And I believe the next slide is another one on workforce. If I could have that next slide, please. There we go, perfect. And I have to thank Larry for this slide. This is in 2018, the percentage of active physicians by race and ethnicity, and 56% are white, 17% Asian, whopping 13% is unknown. Black is 5%, Hispanic is 5.8%, and American Indian or Alaska Native is 0.3, I believe. So really very, very little representation. So it's pretty homogenous.
All right. So what has insurance coverage or lack thereof meant for racial ethnic disparities? And specifically what I want to get into, Deborah, is has the Affordable Care Act provided any improvement in these disparities over the last 7 or 8 years?
Sure, absolutely. The Affordable Care Act has definitely helped. If I could have the next slide, please. So this is data showing the uninsured people under age 65 at the time of an interview. So this was an interview type survey. So by race and ethnicity, you can see that whites had a much lower rate of uninsured compared to Black, and Hispanics were even far less insured than either Blacks or whites. And in California, I would expect that you would see a lot of this. Interestingly, the right panel shows by poverty status, and we know that ethnic and racial minorities are overrepresented in the poor and near poor groups, which are that very high line up to 40%. And you can see that both of those trend downward, by poverty status and by race and ethnicity, when the ACA was implemented in the fourth quarter of 2013. It has helped. It hasn't completely closed the gaps, but the lines mostly trend downward, and we are narrowing those gaps.
Next slide.
Right, great. So if we look a little more digging into the data, you can see that if we look at specifically who has healthcare insurance, has a primary care provider, and did not avoid care due to cost, if we look at that by income level, the change between 2013 and 2015 is shown on this graph. And at the right-hand side, if you look at high income, above 75,000, there's not much difference between these three metrics, and they didn't change much. So the y-axis is the percentage points of change between 2013 and 2015. So those three lines, they didn't change very much for people who are well off, and we wouldn't expect them to. Those people didn't need the help. Whereas the left half of the graph is considered low income, less than 25,000. And you can see we did have a large increase in having insurance coverage, up to 15, almost 18%. And it's good that we did see an increase in having a primary care provider and not avoiding cost, but it is a little telling that that is not the same as having insurance coverage. So we are still seeing that people have coverage, but it's not doing anything for them, possibly because it's too expensive to pay the deductibles or the deductible and co-pays. So having insurance, it really only helps if you can use it. So yes, we are making gains, but there is more to do. If I could have the next slide, I can show you how. I think there was another slide there. Okay.
I think we omitted that slide for the purposes of time. So we'll jump into services. So I'll ask you this. Are there any specific health-related services needs that are unmet due to race or ethnicity, insurance type, or perceived health status?
Sure. So let's look at the next slide then. Great. So people who couldn't get their medical care, dental, or prescription medicines in the last 12 months, whether they couldn't get it or they had a delay in getting it. The left panel is by race and ethnicity, and this wasn't too bad. Whites and Blacks and Hispanics were fairly close, but you can see by insurance type, the numbers really start to break out, and the uninsured are vastly penalized in being able to access care. Private insurance is, of course, the best, and this really reflects white privilege and having a job that affords you benefits, which we know that a lot of racial minorities have been fairly locked out of those kind of career paths by the socioeconomic consequences of being a racial minority. If we look at the right panel by perceived health status, you can see that people who have excellent or very good health get the care they need, which they don't need much, so that's fine. But the fair and poor health status, we are not doing as good a job for these people. 25%, that's a quarter of the people in this category, weren't able to get or had to delay getting the care that they needed. So this really was not looking good. And the Affordable Care Act has helped in that. Keep in mind, this data is all up until 2013. So there was a lot to be done here. If we weren't serving a quarter of people who were in poor health, it was definitely time to do something. And I definitely encourage everyone to get out and support the ACA publicly, and we can hope that the Supreme Court will uphold it. Many states, the citizens have actually voted it into being when their governor did not actually do a Medicaid expansion. For instance, Oklahoma recently voted to make their state a Medicaid expansion state. And for Medicaid expansion states, these gaps in access have been cut in half or a quarter, and there's not been a big difference, about a half that much, again, less than that for states that did not expand. So having that Medicaid expansion is really critical.
Great, thank you. Next slide. So the last element we'll talk about is timeliness. If an individual needs urgent or emergent care, what is the perception among various racial ethnic groups about their ability to get the care they need?
Right, so left panel again, race and ethnicity. You can see that we see some white privilege here, that people who are in the white majority don't have nearly as hard a time getting urgent care as minority, Black, and Hispanics. And if we look by insurance, again, we have this large problem with uninsured patients up until 2013, and public as well. Insurance was not doing very well. So these were very big problems, and thankfully the ACA is starting to address these, and let's hope we can keep it and expand on it because it's going in the right direction.
Great, we'll go to next slide.
Okay, so I'm from Alaska. I'm no longer what they call a Chichaco, which is first year and haven't been through an Alaska winter. And so what a lot of people don't realize is that when you look at a map that shows the lower 48 and Alaska, Alaska is usually stuck down in the left corner with Hawaii, and it's shrunk down so that it fits. This is actually what Alaska looks like geographically compared to the lower 48. From the southwest to the southeast of Alaska is the same span as the lower 48. Alaska has as much coastline as the entire lower 48. So geographically, it's huge, and many of these communities are subsistence native villages where they can only be accessed by airplane. So access is definitely a problem. However, the Alaska natives were able to retain or were restored many of the land and mineral rights through the Alaska Native Claims Settlement Act in 1978. And so that has given them quite a lot of resources compared to the Native American tribes and Indian Health Services. So they run their own Alaska Native Tribal Health Consortium. They have their own Native Medical Center in Anchorage. They've been doing telemedicine since 1998 through the Alaska Federal Healthcare Access Network. So the Alaska Natives are fairly well served, but they've done it on their own. They really haven't depended on many other sources, and it works well for them, and it really provides an example of what can happen when resources are leveraged and used creatively and taking into account Native population. They also bring people from the villages into Anchorage. They do an immersion training in healthcare. They're called community health aides, and these are people from the community, so they know these people. These are very small villages. Everyone knows each other. Many of them don't run on wristwatch time. So they call it village time because things run at their own pace there. It's a very different atmosphere. So having a community health aide embedded in that community who can then talk to physicians in larger cities and do telemedicine and make appropriate referrals, it really helps. And so again, that ethnic concordance between provider or at least referring person and patient really makes a difference.
Thank you, Deborah. I'm going to pass it back to Dr. Poray to continue with the moderating, or Dr. Lee.
Nope, Dr. Poray is on as well. And I think he has actually a question for each of you, but real quick, I think it's important to understand the difference between, access to care and finances. And that's been a big challenge. And you just made a great point there talking about the Alaska indigenous population there, because of their retainment of certain financial features, have allowed them to have certain healthcare advantages, versus the slide that Jamail put up earlier talked about the Native Americans that are in the IHS system, or Indian Health Services, for those who don't know, and how their finances are 1/3, if not less than 1/2 of Medicaid patients and 1/3 of Medicare patients. And so that makes a big difference in healthcare access. So I'm glad we have your experience to talk about what's going on there in Alaska. And I think Dr. Pere has a couple questions for you.
Well, we are getting along in time, and I was going to ask about the specific challenges, the most impactful challenge there among the Alaskan Native population. Is there anything in particular you would point out as being still a major struggle, the most important struggle?
Workforce representation. There's vanishingly few Alaska Native physicians. We do have the WAMI program through the University of Washington, which does encourage Native American and resident Alaskans to get a medical degree. But again, the actual Alaska Native population is very much underrepresented.
Terrific. Quick question for you, Dr. Naidu. The COVID epidemic has clearly shown that the access to healthcare of your neighbor is important for all Americans because of the risk of infection spreading. Do you see any corollary there with pain medicine?
I do, Lawrence. I mean, this could be a really long answer, but I know we don't have much time. I think the challenge for us in pain medicine is that every physician thinks they do pain medicine, right? I mean, that's why we had the opioid epidemic. And what we're really trying to aim for is access to high quality evidence-based pain care. And that's where all of us are. And the number of individuals doing that all around the United States is actually relatively low. I mean, last I checked, it was around 6,000 or 7,000. You divide that by, the 350 million people in this country, that's not many good quality pain physicians per capita. So yeah, I do think that the effect that we have on our communities is quite large and has a ripple effect on the social fabric, their families, and everything else related to their psychosocial care. So yes, we know that there are health disparities for different races, ethnicities when it comes to pain care, just as we've actually seen for COVID. And so, yeah, there's absolutely a corollary between the two.
Terrific, thank you. So I'll let Dr. Lee go ahead and introduce our next set of panelists.
Great, honored to present Dr. Kaz Amirdelfan and Dr. Brittany Grovey, and they're going to talk about a really interesting challenge in terms of workplace bias. We've talked about patient challenges, but on our side as physicians in practices or institutions or large entities we're a part of, what biases exist in our workforce that could be affecting both how we interact with each other as well as the patients we treat. And so we'll let Dr. Grovey hop on here and Dr. Amirdelfan, and they'll kind of review the different biases we can address. So with that, take it away.
Thank you so much, Eric. Good evening, everyone. My name is Kaz Amirdelfan. I'm a pain management physician in Northern California with IPM Medical Group. We have 18 offices and we employ over 74 physicians up and down the state of California. So we're a very large office. But tonight, Dr. Grovey has put a presentation together that is second to none. She's going to give us some insight into gender and racial bias within the workplace and how we can overcome that. So Dr. Grovey, why don't you tell us a little bit about yourself, and then the floor is yours.
Great. Thank you so much for that very kind introduction, Dr. Amirdelfan. Hi, everyone. I'm Dr. Brittany Grovey, and I'm in private practice here in San Diego, California, Relive Youth Center for Advanced Pain Management, where I practice with my husband and partner, Dr. Jamel Lee, who you guys recently just heard from. I'm really excited to be a part of this panel, so thank everybody for tuning in. During this presentation, we'll set the stage by reviewing the definition of cognitive bias, and then go into a few of the different types of cognitive bias and the data behind them. I'll also review some potential effects of workplace bias and conclude with what we can do to attempt to minimize bias in the workplace. Next slide, please. Perfect. So what is cognitive bias? The definition of cognitive bias from the Handbook of Evolutionary Psychology is written here, but there are two words I believe are worth highlighting. The first is judgment. It's important to note that bias is not a neutral phenomenon. There's a value ascribed, be it positive or negative, and thus bias can have positive or negative effects. The second is the word distorted. The data being interpreted by the mind is being processed through a filter, which may not necessarily produce an accurate representation of the specific situation. Relying on bias prevents one from considering the nuances of the situation, thereby clouding judgment. What bias loses in accuracy and logic, it compensates for with speed of processing. So one can see the evolutionary advantage of these cognitive shortcuts, but as animals with higher level thinking, I believe we have a responsibility to prevent this evolutionary advantage from becoming a disadvantage in our modern times. Next slide, please. So what are the different types of cognitive bias and how do they manifest in the workplace? There are two main categories of cognitive bias. Explicit biases are biases that we are aware of and have conscious control over. And then there's implicit bias, which operates in our subconscious and may sometimes be in direct contrast to our declared beliefs and morality. And this presentation will focus primarily on implicit bias. Although implicit bias operates outside of our conscious control, it affects our thoughts and behaviors, having potentially negative consequences to others and those around us. There are many different types of implicit bias that have been studied in the workplace, and in this presentation, I'll focus on just a few. The first type that I'll be presenting is affinity bias, also known as in-group favoritism. We all have groups we identify with. We can identify on many different aspects. The most common and most obvious is race. There's also gender, education. Where did you go to school? Where did you grow up? Where are you from? What neighborhood do you live in? These are all considered our in-groups. In studies, adults and children as young as 4 years old demonstrated preferences for in-group members. They evaluated in-group members more positively and were more likely to help and allocate more resources to in-group members. Studies have also illuminated the tendency for employers to select candidates of the same racial, age, and gender groups as themselves, further supporting this kind of in-group bias phenomenon. In-group bias can create significant barriers for individuals who do not necessarily fit the characteristics of the dominant culture within an institution. I believe it is our responsibilities as leaders to question our gut feelings about applicants or colleagues, people we may interact with, as these may be rooted in implicit bias. Now talking about gender bias, I imagine that many of us are familiar with the gender wage gap. According to the Q1 2020 data from the US Bureau of Labor and Statistics, females make about 19.6% less than males. And when controlling for specific jobs, females still make an average of 2% less. For women of color, this gap is further widened. Gender bias can also manifest in other ways. And research has demonstrated that the same level of assertiveness was deemed good for productivity in males, but bad for productivity in women. In a similar line of study, male candidates were viewed as more competent even when female candidates possessed identical qualifications. In a study using identical essays, females received lower grades than males unless the essay was on a feminine topic. Gender bias may also manifest as differential opportunities and resources. A 2012 study evaluated racial and gender bias in the university setting and found that emails from fictitious prospective students with white male names received faster responses and were granted access to faculty members 26% more often than Black, Hispanic, Chinese, or female-sounding names. This takes us down to name or racial bias. A 2004 study sent out identical resumes in response to help wanted ads and found that white-sounding names were 50% more likely to get an interview than Black-sounding names. Another study looked at the effect of a criminal record on interview opportunities and found that having a criminal record reduced the likelihood of an interview invitation across both racial groups. However, a white male with a criminal record was as likely to receive an interview invitation as a Black male without a criminal record. In academics, women and minorities wait longer for promotions and are less likely to attain full professorship, even after controlling for factors such as research productivity, prior training, seniority, and career aspirations. I'd like to note that more recently, small studies have demonstrated bias against the LGBTQ community, and I imagine this will be a growing area of research interest in the future. Perfect slide, thank you, Michelle. Biases in the workplace also have negative impacts on diversity, productivity, and work environment. Diversity in personnel results in diversity of thoughts and ideas, and this has been demonstrated in studies in which team diversity increased productivity, creativity, and complex problem solving. Lack of diversity may perpetuate bias in the majority group, who may believe that members of the minority group are inherently incapable of success, just because they have rarely observed the success in practice. On the other end, lack of diversity might affect the attitudes of the minority group about their own ability to succeed within that particular environment or in general. This is part of the reason visibility and mentoring is so important, particularly for members of minority groups. Biased managers may neglect out-of-group employee development, resulting in less opportunities for learning and advancement. A 2015 study revealed that managers who scored higher for implicit bias spent less time managing minority workers, and that employees had higher rates of absenteeism with more biased managers. It is important to note that neither the managers nor the employees reported disliking the other, which highlights the implicit nature of this bias. Next slide, please. So what can we do? We can start by understanding that we all have implicit biases. However, recognizing we have biases doesn't necessarily make those biases go away. Understanding the situations that may increase our reliance on cognitive bias may help trigger us to recognize and avoid it. Studies demonstrate decision makers who are rushed, stressed, distracted, or pressured are more likely to rely on biased thinking. Practically speaking, researchers have found that anonymization, exposure to diverse groups, attempting to take the perspective of a perceived out-of-group individual, and redefining what is considered an in-group leads to significantly less discrimination in the workplace. Despite our best efforts to remain egalitarian, as medical professionals, we are not exempt from implicit bias, but we do have a responsibility to understand, not ignore our own implicit biases so that we can overcome them and make fair, accurate, objective decisions moving forward. Next slide. Thank you. I know I went through the studies pretty quickly. That's probably too small for you guys to see, but those are the references. If anyone wants references to the articles that I reviewed, please feel free to reach out and I'll make sure I send the original articles to you guys. Thank you for Dr. Emmer-Delfin for your help with this presentation, these slides, and all of your support. And thank you to PSPS for hosting this webinar. I believe it's very important.
Dr. Grovey, that was brilliant. I've learned so much the two times that I've actually listened to this presentation from you during our dress rehearsal and this time around as well. But I'm really intrigued with the concept of cognitive bias, and I'd like to ask you a question about it, because this clearly affects a significant number of people in their workplace and their professional environment, especially since it's an illogical reaction. I'm a big believer that change has to start from within, from within ourselves. So is there a way for me personally, for people like me, to be able to mitigate the cognitive bias from the get-go, starting from tomorrow morning?
That's an excellent question, and I can't even pretend to be an expert on implicit bias or the strategies, but I have come across some things in my research that I can talk about. And I agree, change first starts with us as individuals and having the recognition that none of us are immune to bias, and then having the desire to make the necessary changes within ourselves to reduce this bias. I believe that making the necessary changes is the hard part, because we have to actually change our thinking and question decisions that may feel like second nature to us. Ensuring that we have objective reasons for our conclusions is a start. When we have a gut feeling about something or someone, be that positive or negative, we should try to explore the objective inputs that are contributing to that gut feeling and try to understand why they're making us feel a certain way. Another strategy that I came across in my research is redefining the in-group, and I think this is pretty interesting. When interacting with other people, trying to focus on what makes you similar and approaching the conversation with that mindset as opposed to what makes you different. What things can you relate on? Also being an ally and helping elevate the presence and voices of minority groups always helps, particularly in medicine. Dr. Vanderpool, who you'll have the pleasure to hear from in a little bit, recently shared a published article with me that highlighted the lack of underrepresented women in the top tiers of academic medicine, which is unfortunate for many reasons, but particularly because it demonstrates that our future physicians are not being exposed to underrepresented women in the highest tiers of academia. And studies demonstrate that exposure reduces bias, so lack of exposure may propagate it. It's important that students, residents, fellows, and our other physicians are exposed to diverse positions, be it through societies, meetings, presentations, as this helps to normalize our presence and may help to reduce bias as well.
That's excellent. And one last question for you. Obviously, you've had quite an education and you've lived in various parts of the United States. Do you feel that there's a juncture in the educational experience, for example, in the preliminary education, college, medical school, or is it during entering the workforce that we can really make a difference in gender and racial bias?
That's a good question too. From the research that I did for this presentation, I really don't think it's ever too early to start learning about bias. Just thinking about all that we hear about children being bullied in schools now earlier and earlier, particularly because they are different or considered part of the out group. So really teaching kids and children that expanding what is considered our in group, I think will be very important. I know for me personally, entering med school helped me address my biases, particularly because bias training was part of my the curriculum early on. And also when entering med school, at least I was very excited to be learning all these new things and how to be a doctor. And I was much more open-minded about the different ways that I may be unintentionally harming people. So in medicine, medical school education, I think incorporating bias training is also very important.
Dr. Grovey, that was wonderful. Thank you so much. Dr. Poirier and Dr. Lee, the floor is back to you.
Terrific. Well, thank you very much. I have certainly questions for both of you, but we are running a bit long, so I think I'll hold my questions and others until the end, if you don't mind holding on. And so,
sounds good.
Dr. Lee, can you go ahead and introduce our next set of panelists?
Yep, our next panel is going to be a little bit different, a little bit more conversational and interactive, so not a bunch of slides coming at you. So we have Dr. Vanderpool and Dr. Gorey joining us. Let them introduce themselves, but they're very well distinguished, and I've got to know them recently over the past couple of years with similar interests to make big impacts. And kind of the goal of our conversation is to talk about what proactive measures can we take to help address a lot of the issues that were talked about in earlier sessions, especially the last session of how do we address those biases in groups, how do we get our presence out there with the communities in ways we can improve and address all these outcomes. So kind of first, I'd like to let Dr. Vanderpool go ahead and introduce herself and get the talk started.
Thank you very much, Dr. Lee, and thank you to the Pacific Spine and Pain Society for giving us this opportunity to speak about this very important topic. Dr. Gorey and I have the pleasure and the honor of co-chairing the NANS Diversity and Outreach Committee, and this is one of our key tenets, which is outreach. If we can go to the next slide, please. Today, I'm going to speak about three main components of outreach. Both of us will share this conversation, but at first, I want to set the stage. The reason that outreach is important is really to address so many of the issues that we've heard today over the course of this excellent webinar. And that is really to address the issues of awareness, application, and advocacy. There's honestly no better way for us to deal with this in an effective and an interpersonal way than to use our skills and our interpersonal communication to outreach with others within our communities, both on a patient, clinician, and pipeline level. And so with that, I'm going to allow Dr. Gorey to introduce himself and speak a little bit about the work that he has been doing specifically with patient outreach, and also how that can help us address the gaps with advocacy, awareness, and access.
So thank you, Dr. Vanderpool. My name is Jonathan Gorey. I am a pain physician at the University of Arkansas. I also really appreciate the Pacific Spine and Pain Society for having this. And I think a good way to start the discussion is to really talk about why it's important to reach patients where they are. And I think we could step back to why we're having a lot of these discussions and conversations and conferences and webinars. And it's really began with a discussion about disparities. And more specifically, a lot of this came out of a discussion on policing, and that's really spilled over into everyday life. And those started with videotapes and news clips, et cetera. And when we look at our televisions, we see people that are angry because they see what they feel is a history of disparities in treatment. And when you look at the solutions that have been proposed, a lot of them have been centered around community policing and having police that look like the community, that are from the community, and that reach out to the community. And I guess the first question is, how does that really apply to medicine? Because I think it's important to recognize that we also have a history. And some would say we have a history of mistrust, a history of unfair treatment, a history of being treated by a community or providers that doesn't necessarily reach out to every community. And a lot of the patients that we treat have had family or parents that have had challenging experiences with us or with colleagues, or have had challenging experiences themselves. And as Dr. Lee, Jamel Lee really discussed, we have a history of the Tuskegee experiment, Henrietta Lacks, we have Marion Sims, but even looking at our present, which is more important, where Black and American Indians and Alaskan Native women are 3 times more likely to die in childbirth, and a lot of the other disparities that Dr. Derecha discussed. And looking at our field specifically, where beliefs and outcomes and interventions in certain minority groups are skewed. And so getting back to patients, I think this is an opportunity for us to really make a change through patient outreach. And we have a system that works for most of our patients, but some would question whether it works for all of our patients. And if we look at other fields, we can really see how they've addressed lack of access or lack of community outreach. For example, in oncology, in a JAMA paper in 2015, it really demonstrated that Black women and Hispanic women are less likely to be diagnosed at stage 1 breast cancer. And if they're diagnosed, they're less likely to survive. And if you look at the response to that over the past 5 years, there have been a lot of community outreach, community partnerships, education, cancer screening fairs, and those have been proven to really improve the numbers of, the rates of diagnosis and also the outcomes in these communities. Next, if we look at hypertension, there was the 2018 barbershop study from the New England Journal of Medicine, where barbers did blood pressure screening for Black men and encouraged them to do lifestyle modifications or receive pharmaceutical interventions by a pharmacist. And both of those arms showed improvement just by getting out into the community, getting out to patients who may not have sought care, really improved their long-term outcomes. And the lifestyle group showed a 9-point systolic drop, and the pharm intervention group showed a 27-point systolic drop. So getting back to us, how does that relate to pain? And so I think there's significant opportunities for clinical outcome improvement, expansion of the reach of our field, the research in our field, increased trust in our specialty. And because like oncologists and obstetrics and primary care, we know through some of the things that have been presented today that there are certain inequalities in our pain treatment. And I think that there's small steps that we can do to take giant leaps in that gap. Dr. Poirier has talked about speaking, and I have discussed speaking at local churches, for example, and how that's an opportunity to really dispel certain, thoughts and preconceived notions about treatments that we have that can really help our communities. I personally discuss pain issues on a local radio station in my community with an Ask the Doctor segment, where I talk about myths about epidurals and neuromodulation and discuss opioid use and abuse. And so I think one thing that we can learn from today is that whether you have the time or the energy to really get out in the community, which I would encourage everyone to do, I think that if we really learn the history, I think we can understand and make sure that we don't perpetuate it, because I think we really have an opportunity to really seize patients' attention and to really improve outcomes in our specialty. And with that, I want to pass things back to Dr. Vanterpool, because I think we also have a similar opportunity with our physician colleagues that are from different specialties.
Thank you very much, Dr. Gorey. And so that was an excellent summary of the importance of why reaching out to our patients and meeting them where they are, both physically where they are and intellectually and knowledge-based where they are, is so critical to improving outcomes and access to care for our patients. And not just access to care, but as we saw from Dr. Lee's original presentation, utilization of care is also critical. If our patients are not aware of the services that are around or are not fully understanding how this can benefit their quality of life or their life goals, they may not choose to access the care, even though they may have the insurance to allow them to access it. But next, I want to transition us to a very important topic, which is clinician outreach. And to be frank, I wanted to really summarized how clinician outreach allows us more than anything else, I believe, to achieve these goals on a broader scale. And what I mean by that is I mentioned at the intro to this section, 3 goals of outreach being awareness, application, and advocacy. And clinician outreach is a way to accomplish all 3 of those things. First, let's talk about awareness. This podcast, this webinar, is actually an example of clinician outreach with the goal of increasing awareness of disparities, challenges, and how we can both affect our own thought processes and also address those of our colleagues by making them aware or calling out things that may be, whether it is unconscious or subconscious, may be affecting the health of our patients. But there's also a more formal way of doing clinician outreach, and that includes formal education on topics such as how to appropriately evaluate and treat pain. At the University of Tennessee, where I'm assistant professor of anesthesiology and the director of the comprehensive pain program here in Knoxville, we have a conference that we put on annually called the Targeted Pain Treatment Conference. And the targeted audience is actually primary care and non-pain specialist physicians, where we go over how to appropriately assess and treat all causes of pain using multimodal approaches, really addressing what Dr. Naidu highlighted as a challenge, which is that many clinicians are not necessarily practicing evidence-based multimodal pain management, not because of a lack of desire, but maybe because of a lack of knowledge. And so this is an opportunity for us to reach out to our clinician colleagues and help share what we have learned through our own practice of medicine and comprehensive pain management to allow them to better affect the care of their patients. That's just one example. There are many, many more, and I hope that you will stay tuned as we continue to put forth these efforts, both virtually and in person, hopefully one day, to continue our outreach efforts to clinicians. But the third thing I'd like us to talk about, which is critically important, and Dr. Grovey also highlighted how critical it is for our pipeline. And in her highlight, she mentioned how important it is for the patients or for the up and coming students to have representation or to see themselves in the future as something they can potentially achieve. And we've recognized how important pipeline research or pipeline outreach is. And I'm going to let Dr. Gorey speak more specifically about what formal programs have been put in place to help reach out to our pipeline clinicians.
So thank you. I think one thing I wanted to add is I think that we often make the mistake that being an MD like us is really the only way to affect change, especially with pain outcomes. I think there's a lot of ways to really make positive impacts on patients. We need more representation in nursing. We need more representation in engineering and a lot of other fields that we work with on a day-to-day basis. And so as we expose others to our field, I think we can discuss our path, but I think we can also discuss other paths. But I believe the partnership really has to start early. And I think through society, we've really begun to create some of these relationships. One example is that NANS partnered with the Latino Medical Student Association, and Dr. Midralis Diaz Ramirez actually gave a lecture there and introduced the field of pain medicine to medical students who may not have had exposure to our field, and also are able to see a mentor and meet a mentor that looked like them. We're also planning to extend these partnerships in 2021. So I think there's a lot of things that we all can do, even really small things. Sometimes just an encouraging word to someone that we see or that we feel is really talented, or an invite to shadow can really change the arc of someone's career. And with that, I'll toss things back to Dr. Lee.
No, thank you. I think, what you guys mentioned is critical, the 3 aspects of our communities, the colleagues, and then the future. And working on those is critical. I think for a long time, we've done a terrible job in pain of educating physicians what we do and then what we do, and then especially our communities of what we do. And so getting out into those areas can make a huge difference to support and affect change. Lawrence has a couple questions for you. And then after that, I know we're running a little short on time, but after your 2 questions, we'll have Dr. Jason Pope join us, and we'll kind of do our last 10-minute session there. So we'll be done by about 7:15. So Lawrence, questions for Dr. Gorey and Dr. Vanderpool?
Sure. So the racial, social, economic, and healthcare disparities have been highlighted by the COVID epidemic. At UCSF, we went from a 5% telemedicine visit rate to 90% telemedicine visit rate in a matter of only a few weeks. My question is, for those patients without a computer or internet access, this was an added hurdle to access to the physicians. How do you propose closing this gap, and do you see a role for social media in addressing this problem? I'll let either
So
one of you.
I'll jump in there. So I personally think that allowing patients to see their physicians outside of a medicalized setting, in their homes, I think where they're more comfortable, I think is a win. But I agree, I practice in Arkansas where it's not too uncommon for a patient to have a flip phone, believe it or not. And so I have a lot of patients who may have poor internet access or poor internet literacy. And so I think that as we expand these programs and expand our ability to connect with patients through phones and through media and through social media, I think that we should partner with community clinics to try to allow patients to have access to physicians that are at distance. And I don't think it would cost, the benefit would outweigh the cost to put in some of these stations to allow patients to connect to other providers. I also do think that social media is a huge tool. I think it allows us to disseminate our research, but I think more importantly, it allows us to appear a little bit human. A lot of you know that I'm pretty active on Twitter, and I think that while I don't divulge a lot of my personal life to patients, I do give some small snippets that allow patients to realize that I'm human and that I experience some of the same things that they experience. And I think that that kind of eases the comfort level to come and share the things they need to share to allow me to help treat their pain.
Terrific, great idea. I have a long way to go to having a Twitter account. I do have one other quick question. I'm on the admissions and selection committee for the UCSF Pain Management Fellowship. We have 150 applicants per year. We narrow that down to 30 interviews, and we end up with 5 slots available. I just finished this a couple weeks ago, and out of those 30 applicants, I interviewed 2 African Americans. My question is, what can we do to better recruit and expose folks to our work, and how can I do a better job at least seeing more qualified African American candidates and entertain their interest in our program?
Well, I can take a stab at that only because I've been able to, personally, as we've been in the process of recruiting for our institution, and also just as a interviewer for other community programs, I found that it can be quite challenging to judge based on interviews. I would highly recommend Malcolm Gladwell's most recent book, Talking to Strangers. The audiobook is fantastic. And in there, he highlights 3 challenges that make it very difficult for us to adequately and accurately perceive strangers, as he calls them, folks that we do not know personally, but also ways that we can overcome those challenges and hopefully get more diverse folks through our screening processes, because often that is the first hurdle. Dr. Gorey just recently published an article on some of the challenges with admissions and some of the challenges with some of the metrics that we use to screen from some of our candidates. And what we found is that if our systems are set up to screen out diversity, whether it's intentional or not, it'll be very successful in doing that. So we may have to reevaluate our screening systems before we even do the first rough cut to allow or to encourage those to come for their interviews.
Great, thank you very much. Guess we'll hand it over to Jason Pope now.
Great. And so, we're honored now to, have Dr. Pope get on the webinar and the broadcast. And I appreciate your time. And I know when we first, got involved with the society, all these issues were bubbling around in your head and critical. And so the challenge, which all these different challenges facing us and all these different issues to address, is how does a society, our specialty, and industry all kind of work together to address these issues? And I'd just like you to spend a few minutes on your philosophy and how you think we can make effective changes.
Well, Eric, I appreciate the kind introduction, and I'll expand a little bit that I have the privilege and the honor to be chairman of the Pacific Spine and Pain Society. I'm president-elect of ASPEN, and I've served on numerous boards, both internationally and nationally. Most recently, I just exited NANS. And as Eric describes, one of the things that we did when we wanted to empower our members and empower our community and empower our colleagues is to create a society that does action. And there's a lot of coverage surrounding things and identifying potential challenges and issues, but I think there really is a call to action that we need to have. And as recently highlighted through all the issues that we see on the news, I think COVID has brought us together to some degree, exposing us to an opportunity to have webinars like this, where we can get together and talk about issues, whether it's medicine or whether it's injustice or whether it's inequality. But a really good friend of mine told me some time ago that if you don't know, you should ask, and then you should diligently listen, and that education is really critical. And I think as a society, that's something that we really need to do. And I'm just so impressed with our Diversity and Inclusion Committee, having put this together in such a short time and having assembled the spectrum and the quality speakers that we had to try to highlight some of these challenges. When we think about our pain space, I think largely we look at what can we do in our own practices, what can we do with societal action, and what can we do with partnerships with industry. And I'll just comment on a few different things. I think the first is that we value ourselves as being evidence-based physicians, and we reviewed a lot of data tonight looking at some of the highlights surrounding some of these inequalities and injustices. And I think big data is important in continuing to highlight these challenges and I think appropriate care for folks. And so I think we should, as a society, develop a registry strategy to capture data to allow us to improve patient care across the spectrum. It's interesting, I have a practice in Northern California serving Sonoma, Napa, and Lake County. I think what's really interesting is we talk about the access to care, and although people are insured and they meet the biologic inclusion criteria to get some things done, the finances surrounding their insurance coverage does not allow it. So we have a medical coverage policy here in California and in Northern California called Partnership, which is our Medicaid program. And largely, even though someone can have failed back surgery syndrome and have failed more conservative therapies, we offer them neuromodulation. Even if it gets approved by the insurance carrier, it's really challenging to find a facility that would allow us to do that because of coverage, because of cost associated with the procedure. And so I think we as a society have an opportunity to really delve into allowing access for patients that have clear biologic needs, but unfortunately don't have the resources from an insurance coverage perspective. And so that's something that I think we should empower our advocacy and policy committee to continue to do. I think one of the other things that's important when we talk about access to rural areas, education is critical, not only for pain providers, but also for primary care providers. My grandmother lived in rural Virginia before she passed away, and she had failed back surgery syndrome, and she didn't even know, nor did her community know, what neuromodulation was or what some of these minimally invasive spine strategies that we now commonly employ in practices. They didn't even know that. So part of our charge as a society is to educate these folks and then to offer a referral strategy to get them to people that can do these things appropriately. I think also, I'm again truly honored to have such an active diversity and inclusion committee, and that goes under the leadership of Ramo Naidu, Eric Lee, Kaiser Elmer Delphon, and we decided to take it upon ourselves as a board action to fund a non-for-profit focused on some of these injustices that we see in our society. And I think that we're trying to put our money where our mouth is and saying that we identify this not only as human beings, but also as healthcare providers. And then as a society, we want to try to fund something that our members can be proud of, that was voted on by our board with overwhelming support. So I think all those things are really critical. And then also, as represented in our membership, but also represented in our leadership, we really want to make sure that we continue to have a heterogeneous population, not only specialties. So we pride ourselves with having neurosurgeons and orthopedic surgeons on our board, but also pain providers, physiatrists, psychiatrists, but also to make sure that we have, I think, appropriate representation from gender and race, and so I think that's really, really critical. I know I'm running a little long, so I'm going to try to shorten this up really quickly. In terms of industry partnership, I think, you know, we live in a space now where we have the ability to enact change by having a clear conversation with industry, and if you do so well and intelligently, they do listen. And when you look at a lot of the advances that we have in our space now, a lot of the things that we are now commonly employing have been made and created with partnerships with physicians. And so moving towards an engagement strategy, looking at research and potential charity cases, having people potentially consider cost reduction for some insurance carriers for those that we can't have, or people don't have access to care because of coverage costs associated with facilities, having education directed to consumer, being culturally driven, and I think also continuing to invest in the ability to remote program. So when people leave tertiary academic care facilities or leave more populated areas and they go out in their communities, having the ability to maintain them in therapy is critical. So having an opportunity to do remote programming for neuromodulation strategies either for movement disorders or pain care, I think is critical. And then also just, you know, really briefly too, I think this 1135 waiver that we've all been operating under since COVID's been involved, I think we need to lobby for that to continue to have people have access in more remote areas, because driving 6 hours or 4 hours or whatever else, as I think a lot of our colleagues described on the call, there are financial resources and burdens that keep people isolated, and having the ability to connect with them over the telephone or connect them with an audio video synchronous conversation, I think is also critical. And I think this webinar is one of the first steps that we have as a society continue to move forward to enact change. And I would implore everybody that's on the call, and I appreciate you for hanging on for the last few minutes, that if there's any questions or if you have any opportunity to engage or if you want to volunteer, we are all ears. And I know that you know, under Eric's leadership, we'll make sure that we get you plugged in.
No, I think you summed it up perfectly, and that's, you know, just, you know, I'll let Lawrence, if he has any closing thoughts, and then I'll give my closing thoughts and let everybody get off of here.
Well, I'd just like to thank all our panelists and look forward to working with everyone, both on the panel as well as our attendees. Definitely reach out to me and the rest of the members of the PSP to further explore these topics.
And I cannot express my gratitude enough for the entire panel. Everybody on this was brilliant and spending your time. And these are efforts. This is a culmination of efforts they've been working on for a large part of their career, condensed into 1 hour, which isn't fair to them. And what's really interesting, I think, that the key take-home point is we talked about, you know, change in ourselves. And that's the first step. And every single person who's on this webinar, all the attendees, you've dedicated an hour to an hour and 15 minutes to listen, to become more aware. You don't have to necessarily understand or agree with everything, but you start understanding that there's an issue to address. And I appreciate that sincerely as a person, as a physician, as a society leader, as a healthcare provider. And so the fact that you guys spent this much time to dedicate to this issue and become aware of it is a huge first step. And we'll create a platform here in our society where we enable people to have power to affect change. And once again, I really appreciate that. For the business side of things, on the current slide now is to log in for your CME credits, and then you can go ahead and claim those. And then the next slide, I believe, is the faculty. Again, just like the whole faculty. Again, if you were going to watch this on a recording, here's another slide. And then again, our annual conference. Obviously, we know it's a world of COVID and where we're at, you know, exactly how that's going to look, but we'll keep you guys updated as we go. We're keeping a close eye on the health system and the health risk here to all of our constituents, and currently still scheduled for September in San Diego, and we'll keep you up to date on all that. So with that, I just want to say thank you so much for your time, for listening to such an important issue, and looking forward to affecting more change in the future. Good night, everybody.
Good night.
Good night.